All right, we are going to start here. So from the very beginning, to see what is the really important things here for you to know. It's just a few things about some processes of the bone. I will tell you what is really here important. So one of the things is important, of course, as you see here, in the frontal bone and the lateral portion of the supraorbital ridge, there is a fossa that we call it the lacrimal fossa. Of course, as you know, lacrimal gland reside in this area. So that area is important for you to know. Other, let's see here, temporal fossa. Temporal fossa, of course, occupied by temporalis muscle and other things that is important for you to know. And the thing is infratemporal fossa. This is all the bounds and all this. We're gonna pass on this. You were examined quite well in this. Things that are important for you to know and remember here. Of course, here's a good picture. This is showed you the lateral wall of the nasal cavity with the three conchae, the superior, middle, and inferior concha. And the superior and middle, as we said, it is belong to the ethmoidal bone, and the inferior concha facial bone by itself. Other things, I'm gonna go to the maxilla. Here, I actually show you here a little bit of the sphenoidal bone. Sphenoidal bone is quite complex, and it has, we said it's just like a bat that is spreading its wing. Here's the other thing that is really important for you to know, that is infratemporal fossa and pterygopalatine. Infratemporal fossa, from the name, it's belong to the temporal fossa or below it, which is infra, meaning, of course, below, as you know, come from inferior. So inferior to the temporal fossa. And then, as you see, this is a lighter color in here that is highlighted. And then that you see the deeper one, the darker color, that is cone shape, that is pterygo. And where's this name come from? You know, here the pterygoid process of the sphenoidal bone. And here that you see deep in here behind the maxilla is the vertical plate of the palatine bone. So pterygopalatine is, you can tell, is something between the pterygoid process and the palatine bone. A lot of those names actually that you are studying in here, really the name will give you clue what it is. It's a lot more anatomy than ever before because the terminology changed through the years and make it a lot easier to relate it to. So this is one of them, pterygopalatine, that the name will give you clue where it is. But those foci, the two of them, one in the more superficial, one in deeper area, there are so many structures that are important for you to know that are located in this. One of the things, axillary artery pass through this infratemporal fossa and then continue through the pterygopalatine fossa, then enter the orbit through inferior orbital fissure. So it comes through here. Another things that is important for you to know what reside in this infratemporal fossa is the pterygoid plexus of vein. And what did we say? Plexus is anastomosing small. Anastomosing meaning connecting together bunch of small vessels that are connected together. And they are located here in the infratemporal fossa. So those structures are extremely important for you, and you will see why sometime in the near future. So another things what really reside in this fossa is pterygoid muscle. You have medial pterygoid muscle, lateral pterygoid muscle. Both of them are attached to the lateral pterygoid plate. To remind you what the pterygoid fossa is in between the medial and lateral pterygoid plate. So altogether, the fossa and the medial lateral pterygoid plate form the pterygoid process. And two pterygoid muscle, the lateral pterygoid muscle, attached to the lateral pterygoid plate. The medial one attached on the medial aspect and the lateral one attached on the lateral aspect of this lateral pterygoid plate. So as you see, there are so many delicate organs that are located in this foci that you really have to have your attention. So in addition, of course, maxillary artery, the pterygoid plexus of vein, the medial pterygoid muscle, and lateral pterygoid muscle. And in the future, you will see more structure or delicate organ passing through this foci. So make sure that you know it really well. So what do you have the boundary of this fossa? Of course, you have the vertical plate of the palatine bone, you have the maxillary tuberosity border, you have the pterygoid process in the posterior border, you have here, of course, the ramus is removed, but you have the ramus of the mandible and you have the zygomatic arch forming the lateral boundary of this fossa, the infratemporal fossa. So all this boundary tells you exactly where it is located. So this is really important for you. And here, as you see, maxillary tuberosity is in the back of the body of the maxilla. Of course, here, as you see, inferior orbital fissure, this is what connect the orbit to the infratemporal and pterygopalatine fossa. And here, as you see, that how the muscles are located in this fossa, the infratemporal. So you have the lateral pterygoid muscle and the medial pterygoid muscle. All of them are located in this fossa. The other things, I'm going to move to the mandible. This is chapter 3. Can you see this here? Can you see the PowerPoint? Yes, good. All right, so this one here, the facial bone. The things that I like to go to, of course, you the vulnar and articulation. Oh, you cannot hear? Can you hear me? Can you hear me? We can hear you, but yes? Okay. A text from Judy that she couldn't hear me. Judy, can you hear me now? Okay, so I'm going, yeah, to see this again. Okay, so here, maxillary, of course, maxillary bone. It's paired bone, and it has, of course, the alveolar process of the maxilla. And you have the maxillary tuberosity on the back of the maxilla. The maxillary tuberosity is very important. I'm gonna just pass on here. This is, as you see, the palatine processes of the maxilli. And you have here the horizontal plate of the palatine bone. And this one here is perforated by the greater and lesser palatine foramen. This is here, Judy is actually texting me. All right, I was going to, yeah. So in here, that the greater and lesser palatine foramen is posterior lateral to the heart palate. And that you have in the front here, of course, you know this foramen by now, that it is the incisive foramen. So through this foramina, the greater and lesser palatine foramen that is posterior lateral, the greater and lesser palatine artery emerge from this foramen. So the greater palatine artery that emerge from greater palatine foramen and ending around the area of the canine. So from both sides, the lesser palatine artery emerge from the lesser palatine foramen and goes backward to supply blood to the soft palate. Of course, here you're not going to see the soft palate because here it's just a bone. Then from this foramen here, the nasopalatine foramen, or another name, incisive palatine artery emerge, and it goes right and left. So both of them, as they emerge from this foramen, they split. Some of them, one of them goes right and one of them goes left, and anastomosis with the greater palatine that coming from the back to the front. Nasopalatine coming from the front to the back. They anastomosis together around the area of the canine. So those foramina, now you see what emerged from this foramina. Of course, in real life here, that you have the incisive papilla covering the incisive foramen. So you have underneath this mucous membrane, you have an artery, of course, supply blood to the mucous membrane. Otherwise, we will not have a mucous membrane. So supply blood to that and supply blood to the lingual gingiva of the maxillary anterior teeth, all from the canine to the canine. So all this area here, interior of the hard palate, supplied by blood from the nasopalatine artery. The back of the maxilla, all this area in here. Of course, you have right and left, so each one of them give a blood supply to you have the greater palatine artery emerge from here and goes all the way supplying blood to all this area, the bone, mucous membrane, and lingual gingiva of the maxillary posterior teeth. So that's actually is really important for you to know. So here that we are talking about the bone and the opening in the bone and opening. We have actually another here foramen that from the sphenoidal bone that goes into the nasal cavity, through which the nasopalatine or sphenopalatine artery, which is a branch of the maxillary artery. So enter the nasal cavity and give a blood supply to the nasal cavity, to the conchi, and then to the septum, both. So give a branches to supply the whole nasal cavity. As you know, the nasal cavity is covered by mucous membrane, and this mucous membrane is very rich in the blood supply. This is all talking about anesthesia. We will come to those things, so I'm not gonna focus on that at all. I'm just gonna pass by it, and you don't have to worry about it at this time. So this, of course, again, that here, so now is important. I'm going to go back to here. So the mandible is another actually really important bone for you because you are working on this very much actually clinically. So what you have is a basal bone, that this part here, you have the ramus, which is the ascending part of the jaw, and then you have the alveolar process, which the part of the mandible that containing the alveoli, which of course are housing the root of the teeth. So you have the ramus here joining the body of the mandible by what we call it external oblique line. As you see it here is how the ramus joining the body of the mandible is exactly like that. So you have the anterior continue with the body of the mandible by external oblique line. And what you have here inside, internal oblique line. Another name for internal oblique line that you know by now is mylohyoid line. Where does mylohyoid line come from? Of course, you know it is the site attachment for the mylohyoid muscle. So left, they unite together in the middle. And that's the internal oblique line is named after that. Let's see if we have a better picture for that. Here, as you see, is too extensive and they take you so much detail and so many things. It's good to have the detail, but each detail, it has its is what you see, the internal oblique line. So this is where the mylohyoid muscle attached to. And again, you know what oblique is internal. So we have internal oblique line and we have external oblique line where the anterior border of the mandible attached to the body of the mandible. Now between these two, between the internal and external oblique line, you can see like triangular configuration that we call it retromolar triangle, as it is between that. So it is distal to the most distal tooth in the mandible and kind of squeezed between the anterior border of the ramus as external oblique line, continue with the body, and you have the internal oblique line. Retromolar triangle in real life, it is actually occupied, is right in here, occupied by something that we call it retromolar pad. That's what in real life occupied that. So in the bone, retromolar triangle, and real life, retromolar pad. So those are important for you because also you will see related to the anesthesia that you will be actually focusing on this area. So you have it right in here. This is, sometimes it looks a little bit radio opaque on a radiograph. So the retromolar triangle is just right in there. So that's an important things for you to know in here. And of course, what you have here is a mandibular condyle. The mandibular condyle that and the TMJ joint is the part of the mandible that participate in the joint. And as you know, condyle is a process on the bone that is involved in a joint. And in this case, we have the mandibular condyle. Another things that you have here, it's a little tiny tubercle projection on the bone and the medial aspect of the mandible that we call it, or sometimes we call it mental spine. Mental, of course, coming from mental protuberance, but in this case, it's on the medial aspect of the bone, it's not on the outside. And the genial tubercle is where two muscles that you know are attached to it. One muscle that you know is belong to the tongue that we call it genioglossus that is attached to here. So genioglossus that you know originate in the genial tubercle and insert in the glossus, which is the tongue. The other muscle that you know that carry this name is geniohyoid, which is just inferior to the genioglossus. But the name of those muscles really give you their story. The origin and insertion could be either the tongue or could insert on the hyoid bone. And that's really what the name implied to. That's why those muscles, they used to have name that does not give you any clue. And here again, the retromolar triangle that is occupied by the pad. Here's the muscle, the mind is considered one of the suprahyoid muscle. So we said we have muscles that are suprahyoid and we have muscle that are infrahyoid. The suprahyoid muscle and infrahyoid, they actually function during swallowing, and another function for them, depressing the mandible. We have three of the muscle that are suprahyoid. Because why do we call it? Some of those suprahyoid muscle, some of them are anterior to the hyoid bone, which is this one here. Some of them are posterior to the hyoid bone. So the anterior suprahyoid bone function in depressing the mandible. Both together, suprahyoid muscle, anterior and posterior, play a role during swallowing. Elevate the hyoid bone, which is the tongue is elevated because the tongue is attached to this hyoid bone and is elevated to contact, of course, the soft palate, and soft palate is elevated to contact the posterior pharyngeal wall. So one of the very important muscle, of course, the mylohyoid muscle, again attached to the mylohyoid line, and then you and forming. This is a muscle that form the floor of the mouth. So we have here, it's just telling you here how important for anesthesia. This one here is really important kind of view that to see some ligament to the TMJ. There is 3 of them, and what you see here is 2 of them. What you see is the sphenomandibular ligament and the stylomandibular ligament. As you see, is both of them like a thick fascia that can again accessory organ. They're not really on the joint itself. They stand up. I consider it just accessory organ, just like you have the hair follicle and the sebaceous gland and all kind of sweat gland are accessory organ for the skin. Those 2 ligaments are accessory organs for the TMJ. So sphenomandibular is from the spine is the sphenoidal bone to the langula, which is a little tiny projection just near lamin, and stylomandibular from the styloid process to the angle of the mandible. Of course, with this mylohyoid line, you have fossa beneath it that is inferior to it, and you have a fossa that is, those fossae are submandibular and sublingual fossae, that the submandibular salivary gland and sublingual salivary gland reside on those fossae. So here, this is really what it is in here that are important. So we can close on that. So the muscles here are the muscles as 2 things that are really important for you, as you know, to remember is origin and insertion. And the muscle that are, of course, in the neck area, most importantly, sternocleidomastoid muscle. Remember this muscle because we are going to come back to it again. Important. The other muscles that are important are the muscle of facial expression. All those muscles that you can vary the appearance of the face by a different combination of those muscles. So some of the muscles, let's say, elevate the upper lip, which what we call it levator labii superioris, and some of them depressing the lower labii inferioris, and then you have some of them on the corner of the mouth, depressor anguli oris, levator anguli oris, and then you have the one that is here, the levator labii superioris alacunasii, from the name the ala of the nose. So this is elevate and open the nose active when the sneering and the sneering expression, this muscle open the nostril. The other muscle that are really quite important and stubby, particularly for people who have, let's say, denture, is a mentalis muscle, which originate from the inferior border of the ramus and insert in the chin. So when this muscle contract, it will shorten the vestibule and dislodge the denture. So those are really important. Then, of course, you have orbicularis oris, you have orbicularis oculi, and all this. And then we still see the same slide. Okay, if you still see the same slide, I'm gonna stop then sharing and share again. Can you see it now? Okay, can you see it? Okay. All right, you can talk actually too, is to make it easier. So here you have again this, I was talking about this slide in here that you see here, the levator labii superioris nasii alacunasii, that is open the nostril. You have the orbicularis oculi, you have orbicularis oris, from the name orbicularis that you know it is the area whether it is the eye or the mouth, and then you have the mentalis that shorten the vestibule because it is just right in here. It's inserting in the skin tissue of the chin. Here, as you see it, another one that you see, platysma muscle. Platysma muscle that actually attached to the skin immediately. So muscle. And here the triangular shape that you see it, depressor labii anguli oris. So you see there. Zygomaticus major and minor, of course, elevate the upper lip, and this is being active during smiling. The nerve, facial nerve. So if the facial nerve is injured, the patient may have paralysis of the side where the nerve is injured. This muscle here, buccinator muscle, is very important one. Of course, from the name buccinator, that it is in the buccal area, which is the cheek area. This muscle here, it has vertical fibers. So this muscle shortens the cheek vertically and horizontally. This muscle considered one of the helper of the muscle of mastication. So in this muscle, the one that the duct of the parotid gland piercing this muscle because it comes from outside here and pierce it to open and the epicenter by the parotid papilla, which you might find it against the maxillary second molar. This is another really important picture here that to show you quite clearly these two folds that separating the oral cavity from the oropharynx. So you fold, it looks like sphincter that we call it anterior fascial pillar, and then the one behind it that is posterior fascial pillar. Between these two fascial pillars that we have the palatine tensils. So what make up what is under the mucous membrane of this fascial pillar? The under it is palatoglossus muscle. And what make up the posterior fascial pillar is palatopharyngeus. So from the name, you can conclude where this muscle originate and where does it insert. So the anterior fascial pillar originating from the middle of the palate and then insert on the lateral of the tongue, and both together, right and left, forming a sphincter. So when those muscles contract, they seal the oral cavity from the oropharynx. The other one, the posterior fascial pillar, as you see, that is also could help sealing the oral cavity and could elevate the lateral wall of the pharynx. So that's a really good picture in here. So I'm going to pass on all this muscle of facial expression, and actually you did examine by those muscle here. So I'm gonna close on that, and I will say stop here. And so, well, I want to really share with you another, not this one here, the muscle of mastication. Let's see, what is this one here? Okay, we're gonna share this and then we're gonna come back to muscle of mastication as we close this. And I have so many windows open, so if we just eliminate them, it make it a little bit easier. So the vascular system, what you really need to know about that. So we will come back about the muscle of. So the really very important things to know about the vascular system that our artery is starting big and then becomes smaller. And the vein is starting small as capillaries and then converge to becoming bigger. So here what we have, how here actually this is a really, you have here with the oxygen and nutrient and become very small capillary. At this level, the blood exchange gases, nutrient, and waste product with the cells of the tissue and then become the waste product and go back to take them to the heart. The heart send them back again to the, of course, eliminating organs. And anastomosing together, when you have all these little tiny vessels, they are. The venous system has very freely anastomosis, more so than arterial system. But the origin from the heart, the first, of course, here as you see how the exchange of the cells, here are the cells of the body. So they give them nutrient and they take waste product going back. The origin from the heart is, of course, the first one is so the aorta again originate from the left ventricle, and it goes upward, and then very soon, after a very short time, it make a U-turn to becoming abdominal aorta. But at this U shape, then the first vessels that give blood supply to the head and neck area arise from this the aorta making the U-turn. So in the left side here, the common carotid artery and subclavian vein, which is a final destination, is to the upper extremity. So they both of them arise from the aorta. But on the right side, what the first thing arises from the aorta is then brachiocephalic split into common carotid artery and the right subclavian artery. As it goes up further, then the common carotid artery is split into internal and external carotid artery just in here. So internal carotid artery goes into the cranium and supply blood to the cranial structure. And this is a very reliable artery for having the blood pulse. It's always reliable, more so than the brachial artery, which usually used if the patient is fainting or if you want to take, but sometime when patient is fainting, the brachial artery become a little bit weak, and sometimes it's not easy to find it. In carotid artery, you can always find it. So the other bigger branch of the common carotid artery is external carotid artery. And this here, of course, from the name external, supply blood to external structure. That's including the face and the skull and the oral cavity and the nasal cavity, everything of your interest is supplied by this external carotid artery. So this external carotid artery, the most important, really of your concern, that you have the lingual artery. It goes to the tongue, and the tongue, of course, is important to you because you will be working in the oral cavity. So supply blood to the tongue, to the floor of the mouth, to the suprahyoid muscle that are located in the floor of the mouth, and supply blood to the lingual gingiva of the mandibular teeth. The other artery that is really important to you is this facial artery that is considered one of the anterior branches of the external. So as this facial artery arise just medial to the ramus, then wrap around the ramus, around the inferior border of the mandible, and then course to end up in the corner of the eye. As it courses that way, and its way give branches throughout its way. So one branches, it goes to supply blood to the submandibular salivary gland, to the submental area. It goes to the lower lip, everything in the lower lip. That's including the muscle, and in the upper side of the nose and the cheeks and all. And it gives the blood supply to the muscle that are in its way. So it just like you can imagine post office or mailman that come to a community, and he has, or UPS. So it comes to the community, and in that community, let's say there is 100 house that is gated community house, and give their mail to it, wherever he needs to drop in there. That's what the facial artery does to the face and everything in the facial expression muscles. So all the muscles of the lower lip, upper lip, side of the nose, and the cheek, and all this receive their blood supply, all the nutrient that they need from this facial artery. So facial artery, as you see, they do match really well. And this one here, the end up of it is the side of the nose. So again, that's actually what give a blood supply to the skin here of the side of the nose. There is another actually branch of this facial artery, the first one, which is not seen in this area, that it goes into the blood supply to the soft palate and the muscle in the soft palate. So in the past, tonsillectomy, ectomy meaning the removal, if somebody have tonsillectomy as a result of a frequent infection, sometimes they used to remove it, take it away. And the removal of that is actually may cause a bleeding. If they bleed, the blood is from this facial artery. That's the sort of blood if somebody bleeds as a result of tonsillectomy. Other branches that they go backward, you have to the occipital, and you know where is the occipital area, and you have posterior auricular, you know what the auricula mean, and you know what give a blood supply to the scalp and that area, just in the back of the whole scalp. Then you have the final branches, which is the terminal branches of this. At some point, this external carotid artery is going to end. So there's two branches where they end, two major branches. The two major branches are the superficial temporal artery. What you expect is just immediately under the skin. So you may sometimes, if somebody have thin skin, and let's see, he is a bald guy, let's say, older bald guy. So you may see this artery quite clearly under the skin as the skin becomes thinner. The other final branch is a maxillary artery. So the temporal has a few branches that have a name, that is frontal branches, parietal branches, and then they have a branch that it goes a transverse way along the zygomatic arch. And what goes along the zygomatic arch too? It is the duct of the parotid gland. Let's see if we can find a better picture. So this is all facial, as you see how it gives a blood supply to the facial expression muscle. So generally, if you have the question, which artery supply the muscle of facial expression, your answer will be immediately, that's facial artery. So here the superficial temporal is actually focusing on that. So that's frontal branches, parietal branches, and you have a little tiny here, little tiny branch that we call it the transverse facial artery that supply blood to the parotid salivary gland duct, because actually it is parallel to it and it's a very much nearby it. branch also in here that supplies some blood to the temporalis muscle. The final branch with other final branch, which is the maxillary artery, that's a very important to you, and it has several branches that are most important. So this artery, first, they arise from the external carotid artery as a final branch, and just a branch near the mandibular. And here's the maxillary artery that passes through the infratemporal fossa, and then they go deep into the pterygopalatine fossa, then they enter the orbit. As it enters the orbit, you can say this is the final branch or the final how the maxillary artery ends by becoming infraorbital. Let's see if we have a little magnified picture of that. So here it is as you follow it, starting in here, infratemporal fossa, pterygopalatine fossa, entering the orbit, go through the orbit, become infraorbital, then exit from infraorbital foramen to supply blood to all nearby, let's say, lower eyelid, side of the nose, side of the cheek, upper lip, anastomosing with the facial artery. Now, in its way, so that's a major course. Starting here and goes through the foci, both of them, enter the orbit, become infraorbital, ending up in here, infraorbital foramen. And its way, as it goes in its way, just like the facial artery in its way, give a blood supply wherever they are. So you can imagine facial artery like US post office, and you can is UPS. So also UPS as it passed by the community, or now that you see them, the Amazon Prime. I see them here in my community. Sometimes I see 2 trucks at one time. So they delivery things. You can imagine every house they drop, and every house they drop a little package. So that it is here. They have a kind of track, and in its way, and this branches here and there to everybody in its way. So one of those branches that they give is inferior alveolar. From the name tells you where does it go? Inferior. What does really inferior refer to? Inferior refer to the mandible. That's the inferior jaw versus the superior jaw. So inferior alveolar, of course, into the alveolar canal that we have. How does it enter the canal? Through mandibular foramen. Where is mandibular foramen located? In the medial aspect of the ramus. So it's enter the canal, as in enter the canal here, during its presence in the canal, it give a plexus, what we call it, inferior dental plexus, that to supply blood to the mandibular posterior teeth and all out here. At the mental foramen here, this inferior alveolar split. Branch again. One branch exit the foramen as mental artery to supply blood to the skin tissue of the chin, anastomosing, of course, with the facial artery. The other branch of this inferior alveolar stay in it and give a blood supply to the mandibular anterior teeth and facial periodontium. Yet here, before this inferior alveolar, just before enter the foramen, it give another branch. This is the mylohyoid branch. The mylohyoid branch, from the name, where do you guess it goes? It goes mylohyoid muscle. So this one here then has 3 branches. The mylohyoid before it enter the bone, and then at the mental foramen give the incisive and the mental. So that's very important one. The other branches, the branch off of this maxillary artery, simply going to the muscle of. So each artery or branch of this maxillary carry the name of the muscle. The deep temporal, the mesenteric, the pterygoid. From the name, you know where their final destination. So by now that you see maxillary artery, take care of muscle of mastication. Facial artery, take the facial expression. Simply as that. So as it continue then, it goes, you have here also a kind of buccal artery, but as continue, and the pterygopalatine fossa, it give another branch that is very important, and that's the posterior superior. Where did you hear posterior superior alveolar foramen? So as you see, those two names are belong to each other. They match. Posterior superior alveolar artery enter the posterior superior alveolar foramen. So it goes into the superior here, superior jaw, and they give here dental plexus, giving blood supply to the maxillary posterior teeth and their facial periodontium. You may say, how the maxillary anterior teeth get their blood supply? That would be from branch from infraorbital. So while this infraorbital still in the canal, descending in the front of the wall of the maxillary sinus and give branches to the maxillary anterior teeth and their facial periodontium. So simply then, you have the maxillary posterior teeth, posterior superior alveolar, maxillary anterior teeth, and alveolar. I think it's make sense and it's really easy for you to remember posterior superior and anterior superior. Both of them related to the maxillary teeth. Inferior alveolar, mandibular posterior teeth. Incisive, this is the one that is a little bit odd. It's not too odd because inside, just you have to distinguish between incisive artery and incisive foramen. It's slightly tricky in here, so you pay really good attention to it. The other actually artery branch from this artery is this one here that it goes into canal. I think we have a better picture for that one. Descending palatine artery. Gonna find a better picture to see this one here. The descending palatine artery. It's another branch from the maxillary artery that descend into this pterygoid canal and again emerge into the palate as a greater palatine artery and lesser palatine artery to supply blood into the palate and of the maxillary posterior teeth. Another branch of the maxillary artery, as you see, you have like 4 branches, is sphenopalatine. So here the sphenoidal bone, and here you see the sphenoidal sinus, and here's the nasal cavity. which what you see here making the lateral hair wall of the nasal cavity is actually the palatine bone. So you have foramen. Through this foramen, sphenopalatine artery enter the nasal cavity to give a blood supply to the nasal cavity. That what do we have in the nasal cavity is conchi and septum. So the conchi and septum, both of them are really quite rich of a blood supply, all coming through the sphenopalatine branch. From the septal branch, you into the nasopalatine canal and then to emerge into the anterior hard palate, right and left, from the right canine to the left canine, to supply blood to the anterior hard palate and the lingual gingiva of the anterior teeth. So here I recommend you that try to label those here. Particularly, this is really important. At the back of your book, you have all those number. It will be identification based on these pictures and this picture. I mean, there's so many identification, and it's really important that you know those. So those actually here, I'm gonna here try different one. Let's see which this one here. This we're back to the muscular. Okay, I'm gonna do that. Can you see this or you cannot see it? Let's see. Okay, I'm gonna do this and this again. Here, yeah, that's what I want here. Now the venous system. So the venous system now returning back. After, let's say, you have Amazon Prime giving all this mail and packages to the people, and the people want to send some of the package back that they don't want really, so they give it back. So this mail collecting all these packages and reverting back to the origin. So you have the venous system that is collecting blood from start vein. So facial vein start actually collecting the blood from where the facial artery finish, which is in the corner of the mouth. That starting at the corner of the eye. So it start collecting the blood from there and goes in very much parallel way to the. So for you to know that is artery and vein and nerve all gonna accompany each other. So they return back at the same way. And its way returning back, they collect all this blood from the area that they were supplied by the facial artery, meaning all the waste product from the muscle of facial expression. From this its way, all collected back and eventually empty into internal jugular vein. Internal jugular vein originally start from intracranial structure, collecting blood from all this venuses, sinuses, and all this from the cranium and the meninges. from jugular foramen as is exit in its way, the facial vein empty into it. And tributary, you have submental, sublingual, superior labial, inferior labial, all this area empty into the facial vein. And of course, it goes down. Here for you to know because this is route of spreading of dental infection. As I told you earlier, the venous system anastomosis so freely. And there's very few valves in this vein that the blood could reverse back in different way rather than coming down, can go up. The one is ophthalmic vein, which draining the eye here, anastomosing with anastomosis here with the facial vein. So any and in this facial vein you have, let's say, the superior inferior lip could drain into that. If somebody have, let's say, any sore as a result of repeated lip biting and it has infection in that area, so the bacteria and all this could revert back and goes upward and then goes into ophthalmic vein and goes into the dural sinuses, which is the cavernous venous sinus that drain the meninge in there and could the sinus. Another things that is important about facial vein, that also anastomosis with the pterygoid plexus of vein. And pterygoid plexus could be injured during administration of local anesthesia. If you wanted to anesthetize the maxillary posterior teeth, you inject your needle that way. And if you over insert your needle and the infratemporal fossa and injecting your needle, I mean, it's possible and it happened that you may inject your needle in the pterygoid plexus. If your needle is contaminated or if you inject your area an infected area, that may actually transfer the bacteria to the blood in there. And from there, the pterygoid plexus of vein is anastomosing with. So from there, the bacteria could transfer into the cavernous venous sinus. Bacteria can transfer in the blood as what we call it bacteremia. So it's all possibility, and that's why you are studying this anatomy to know where the delicate organs are and to be very careful with that. It's going to come to time and we will study about local anesthesia and we will see how that could happen. But for that all this connection together that we call it anastomosis, it's really crucial for a transfer of infection caused by dental procedure, whether it is infection from contaminated needle, contaminated surgical site, injected needle in infected area, all could compromise this. And this is really one of them. So again, the facial vein eventually end up in internal jugular vein, and it does anastomosis with the pterygoid plexus. Now the other things, pterygoid plexus, now all the structure that are supplied blood by the maxillary artery, the blood then returning back to the pterygoid plexus. Let's say your alveolar vein that collecting blood from mental vein, from incisive vein, from the inferior dental plexus vein and then returning back to pterygoid plexus. The posterior superior alveolar vein collecting blood from the maxillary posterior teeth and their facial periodontium, returning back to pterygoid plexus. The anterior alveolar vein, the sphenopalatine vein, after exchanging the blood and collecting waste products from the nasal cavity, they return back to the pterygoid plexus. From the pterygoid plexus, all this blood collected to start the maxillary vein. Maxillary vein then superficial temporal vein. Where do you think superficial temporal vein collecting blood from? From frontal and parietal and temporal and from transverse, all this area that's supplied by superficial temporal artery. The blood returning back through superficial temporal vein. Now, both together, maxillary vein, superficial temporal vein, converging to form another bigger vein that we call it retromandibular vein. From the name retromandibular, it's quite short vein behind the ramus. And just behind the ramus, starting from the collection of maxillary and superficial temporal, then let's say angle of the mandible is split into anterior canal division and posterior division. The anterior division here combining with the facial vein. Let's see if we have better picture. Combining with the facial vein. And both together form really short vein and then ending up into internal jugular vein. What happened to the posterior division of this? The posterior division here, as you see, this is a really good one, combining with posterior auricular vein, both together, starting the beginning of external jugular vein. So finally, internal jugular vein, they combine with subclavian vein. As combined with subclavian vein, both together, here, that's the big one, the internal jugular vein, combining vein, the both together, the conversions, forming the brachiocephalic vein. Brachiocephalic vein, here you have the left side and right side. They combine together to form the final that is superior vena cava. That empty into the right atrium. So that's the final return back to the heart. And that's how the whole journey then ends in here. What happened to the external jugular vein? It emptied into just at the convergence of subclavian and internal jugular, just at that area. Empty its blood in there. So that's about the vascular supply. So generally speaking then, maxillary posterior teeth, they get their blood supply through posterior superior alveolar that supply the pulp tissue Because as you know, bald tissue made of connective tissue that has a blood supply, and the facial gingiva. So you have the maxillary teeth, either posterior or anterior superior alveoli. The facial periodontium. What about their lingual periodontium? The maxillary posterior teeth has the greater palatine artery. The maxillary anterior teeth has nasopalatine artery. So you have 4 arteries for the maxillary teeth. The teeth and their facial periodontium is the same artery. The lingual periodontium, so you have 4 of them. And posterior superior alveolar, anterior superior alveolar. Greater palatine artery, nasopalatine artery. That cover the maxillary teeth. For the nasal cavity, you have sphenopalatine. Now, what about mandibular teeth? Mandibular posterior teeth, you have inferior alveolar artery. You have incisive artery. So this is a little bit the odd name. Why don't we say anterior inferior? Or rather than saying anterior inferior, you say incisive. What about their lingual gingiva? Of course, lingual artery. Lingual, you have sublingual, dorsal lingual, and by the major lingual artery that divide into deep lingual, sublingual, dorsal lingual, all that. Now, muscle of mastication, supplied blood by maxillary artery. Muscle of facial expression, supplied blood by facial artery. Of course, middle meningeal is meninge. It's the name will give you. It's a really simple, more than you think. And rather than study every word in there, just general talk about it like that. What else you have? That's really what it is. So I'm gonna close on that. Let's see here what else left, because I have them all here open. Is open. And we're gonna go like here back and forth. Muscle, here the muscle that we go back to the muscle of mastication. You know the muscle of mastication, the 4 actually muscle of mastication. The masseter muscle, that of course you know where it starts, where does it end. What is important about it? What is its action? Muscle, the masseter muscle, elevate. Muscle of mastication, work with the TMJ. So the muscle of mastication, of course, that number 1, its action, elevation of the mandible. What other muscle also elevate the mandible is the medial pterygoid muscle. So masseter muscle has 2 heads of origin that we said here. Is cut to show you the temporalis, which occupy the temporalis fossa, temporal fossa. Again, insert on the coronoid process. So as the masseter action is elevation of the mandible, the temporalis muscle has 2 of them, elevation of the mandible and retraction of the mandible. Because as those fiber, the pterygoid process or the coronoid process backward. So retracting the mandible. The other 2 muscles, the 2 pterygoid. The lateral pterygoid here and the medial pterygoid. The medial pterygoid is agonist to the masseter, so it's the inside of the ramus. Also, the lateral pterygoid insert on the mandibular condyle neck and the capsule, blending with the capsule. So when this muscle contract, pull the mandible forward and causing protrusion. Of course, those muscles work with the TMJ. So what you have then, opening the jaw, the condyle move forward and down. So it is protrusion and depression. What causes a protrusion is the lateral pterygoid. What causes depression is the anterior suprahyoid muscle. Closing the jaw causes elevation and retraction. What causes the elevation is the masseter, medial pterygoid, and temporalis. What causes temporalis?
Just gotta know.
So all work together that way. Now, sometimes when people complain about some tension in the morning where their TMJ, and this tension probably not really originating from the TMJ, originating from the nearby muscle. Most likely what muscle that is nearby? As a patient probably clenching his teeth during the night, and the muscle is so spasmic when he wakes up and he feels the pain. He thinks the pain is at the joint, but actually is because of the muscle spasm. And this is what we call it, referred pain. So the nearby muscle, which is this one here. Other things, actually, this is really all about the muscle of mastication. Other things about the hyoid muscle, of course, again, the supra and infrahyoid muscle, and we said the hyoid muscle, suprahyoid muscle, what anterior suprahyoid muscle, what suprahyoid muscle, all anterior and posterior, cause elevation of the hyoid bone, and that's during swallowing. Here, as you see, digastric muscle, anterior and posterior belly. And here, as you see, geniohyoid. Digastric muscle forming the submandibular triangle. That's actually what is in here that are important. The tongue muscle, tongue muscle are really important. As you know, you have some intrinsic muscles and extrinsic muscle. So the most important here, let's say intrinsic muscle changing the shape of the tongue, extrinsic muscle suspending the tongue in the oral cavity. So you have three of them, very important one, the genioglossus, that looks like a fan shape. Contract will bring the tongue forward because it originates on the genial tubercle, and when the insertion moves toward the origin, then the tongue moves forward. That's how you stick your tongue out. The other one that you have styloglossus, so that bringing the tongue upward and backward. And this one here, the palato, forming the anterior fascial pillar versus the posterior fascial pillar, as we said, is palatopharyngeus. Now, if you want to change the shape of the tongue, let's say you curl your tongue up, or you say to the patient, stick your tongue up on the roof of your palate so you can examine underneath the tongue, the ventral surface of the tongue. In this case, if you curl your tongue up, actually activating the superior longitudinal muscle. That's what you will be asking him to do. Now, the palatine muscle, we have also 5 of them that move the palate during swallowing. So you will be examining the tongue and so in this case, you ask him to move his tongue in all different directions to, of course, examine that. Pharyngeal muscle, you have the stylopharyngeus muscle and the superior pharyngeal constrictor and middle and inferior pharyngeal constrictor that forming the wall of the pharynx. The whole pharynx is a muscular tube. Here, as you see it from the side, the superior pharynx attached to the buccinator muscle to form the pterygomandibular raphe. The palatine muscle, here you have, and what you have is also 5 of them. The simplest one is the uvula, which is this one here. It's just changing the contour of. Then you have here the palatopharyngeus, from the middle of the palate to the lateral wall of the pharynx. And then you have 2 above, one, of course, attaching to the sphenoidal bone and to the temporal bone. So you have levator villi palatini and you have tensor villi palatini. They are next to each other. And the tensor villi palatini, which is here, you see it better, amylus, and it's tense most of the time. That's the name came from tenses. So the most important that all the palate then actually raised against the pharynx to close the nasopharynx. So the bolus has one way to go, which is to the esophagus.
I can only take one at a time.
The uvula, of course, here the uvula, you can see it here. It's as either short and thick or long and thin, changing the contour of the soft palate. So this is for that. Again, I would really recommend you that to label all this and know all these muscles well. So we're gonna close on that. Left.
Your son, maybe another appointment.
Is there one here? Temporomandibular joint here. I still have that. I still have this open. So what do you need to know about that? Number one, the structure of the TMJ that is made of the articular eminence and articular fossa that belong to the temporal bone and the condyle of the mandible. This is here actually a really good picture of it. So it's exactly as you see it in the front of the external acoustic meatus. So what really joining, of course, here the condyle of the mandible that participate in that. And what you have to know that the joining these 2 bones together, the capsule is this dark blue color. That it's made of dense fibrous connective tissue that connecting the 2 bones together and enclosing this as what we call it synovial joint. Inside the joint, you have meniscus, or what we call it the joint disc. And the joint disc divide the synovial upper and lower synovial cavity. So the capsule joining the two bones together, and the disc dividing the cavity into two compartments, and actually just attach to the condyle and move with the condyle. In addition to that, you have, we saw a little bit earlier, a ligament. Accessory ligament. We saw two of them, and we see this one here is the third one, what we call it the lateral ligament or TMJ ligament, which is in the front of the capsule and reinforce the capsule and prevent the mandible from backing up too much, what we call it excessive retraction, because it becomes so taut and prevent the excessive retraction. So sometimes if any noises happen as a result, as this disc get caught between the condyle and the articular eminence. And again, as you see, the muscle of mastication, they are the one that move the mandible. The mandible by itself, of course, doesn't move. So the two things that you know in here, opening the mandible, the condyle move forward and rotate in the lower synovial cavity. And by the action of the muscle, the lateral pterygoid and the anterior suprahyoid muscle. And when the mandible is closed, the condyle move backward and rotate again on its axis. And masseter, medial pterygoid, and temporalis muscle that cause elevation and retraction. So that's actually about this TMJ, what you really need to know. So we'll close on that.
I know. What day?
The last things is the gland that we talked about. Actually, and this is really simple for you. And that we said the lacrimal gland, of course, you know where it's located, and the lacrimal fossa, and secreting the lacrimal fluid that drain into the nasal cavity. And this actually supply blood by lacrimal artery, which is a branch of ophthalmic artery. Ophthalmic artery is a branch of artery. So the source of blood is internal carotid artery.
Which week?
Salivary gland, you have the parotid gland, of course, is you know where it's located, supply blood, external carotid artery, and secrete serous type of saliva, 100%. And what else you need to know? Contribute about 25%. 25% of saliva. Of course, you know where it's located. The other one, sublingual salivary gland, located in the sublingual fossa. Here it is. Sublingual fossa, which is below the mylohyoid line. So the gland has two lobes and posterior border of the mylohyoid muscle. And the major lobe is inferior to the muscle, a small lobe is superior to the muscle, and then the duct arises from that and open into sublingual caruncle. The saliva that produced from this gland is mixed type of saliva, serous and mucus, and contribute about 60 to 65% of the volume of saliva. They get their blood supply, you can imagine, is the glandular branch of the facial artery, and could be anastomosic with sublingual artery. The sublingual fossa, which is just beneath the mucous membrane of the floor of the mouth, about 10% of the saliva, and again, it's mixed type of saliva, and supplied blood by, again, sublingual, submental, anastomosic together to bring blood to this gland. And where does it open? It opens also in the sublingual caruncle or in sublingual fold. It opened there. I don't know if you saw the case study that was posted for you. It is this picture in here. It has some pathology and some actually probably about a lymph node. If any question that you couldn't answer it, ask about it. You can either ask or you can investigate about it to complete. Even you didn't obtain the knowledge yet, but it's very easy to search the knowledge. And just again, either ask a question or you yourself investigate about it. But that is your case study. I think this is really it about the gland. Thyroid gland, of course, and it has hormone, the T3, T4, and calcitonin, which is antagonist to the parathyroid hormone. I think this is it about this one here. I think this is all really what they are. I think I finished all the PowerPoint that I opened. Any question that you like to ask? Anything in your mind, actually. The thing is, you just really finished it yesterday, but lecture yesterday was very simple, and you didn't really have enough time to study, but the one thing that I know that you were examining and everything that we did talk about. You had it as a quiz, and we review it before the quiz and after the quiz, and you have the time, and this is here one more time that we review. I hope that it is really helpful, and I hope that you will do well. The thing is that is new to you is blood vessels. The gland is very simple for you. just to use a really common sense, what the blood vessels supply, what structure. Well, I really thanks all of you that been here. That was a really quite a good turnout, and I wish you really the best of luck. And I always tell you, if you don't have any question right now and then question arise as you are studying, please leave it for me and ask me in the front of your classmates so everybody can benefit from your answer and your question. I wish you all a good weekend and a good rest of the night. And good night, everyone.